Thank you, Joanne, for that introduction. I'm going to just share my screen, if that's okay. If you could just give me a few minutes. So thanks so much again for the invitation to the Institute of Aging and Lifelong Health. And as Joanne mentioned, I'm going to be presenting a bit of an overview on health for all and promoting equitable and culturally safe mental health care for immigrant and refugee communities that are often also racialized in Canada. I'd like to begin by acknowledging that I'm a visitor to the territory. So I acknowledge with respect the Algonquin peoples on whose territory the University of Victoria stands, and also my privilege in being able to teach, work, and play with the Songhees, Esquimalt, and Wasanich people whose historical relationship continues with us today. So I have a bit of an overview. I'd like to sort of ground this discussion presentation in some global trends around immigration in Canada. And I will be providing a bit of a retrospective analysis. In other words, looking at where we've been, where we've come from, and where we are today. And then just some a brief overview on how we can turn the dial on immigration policy and what it means for health and mental health of our newcomer communities. And I'll touch briefly on some of my work that does that. So just by way of overview, I think many of you are aware of the refugee crisis that has been occurring globally, where we have approximately 258 million migrants, which represents about 3.4% of the global population. And that's consistent with International Organization for Migration that reports that the global migration is expected to exceed to more than 400 million by 2050. So according to the 2016 data on those that experience forced migration, and I'll be focusing our discussion today on particularly groups that have been forced. This includes about 68.5 million persons. Of those, about 25.4 are classified as refugees that have been granted asylum, particularly in the global north. So about 3.5 million represent asylum seekers, and that's due to persecution and violence. And approximately 40.3 million are internally displaced people globally. So you'll notice that I use the term migrant to encompass a variety of movements and situations involving individuals that cross borders temporarily or permanently. And that also includes refugees, asylum, economic migrants, and undocumented migrants. So in Canada, we categorize people within migration categories. So we have frameworks which has led many countries to proliferation of immigrant categories. So these categories are legal and political tools that grant access, so to social, economic, and political rights. But also it's important to note that these categories also include rights to health, and what kind of healthcare services are available. So you'll notice that in Canada, and you're probably aware that legal categories are the asylum categories, the government assisted, or the blended visa, or other categories such as family sponsorship and reunification or economic migration. One thing to note is that if we look at this graph, we see that trends, according to the refugee categories, have decreased in around 2020. That's probably due to the COVID-19 pandemic. But the other thing of note is that privately sponsored refugee groups, that category is on the rise. And that's primarily fueled by the Government of Canada fostering more private sponsorship, which also has implications for family groups and community groups that sponsor newcomers to Canada, it increases their responsibility for healthcare access and all other access around integration. So the global trends, where does Canada sit? Canada sets its quotas about every 3 years for immigration. So that's about 10% of our annual immigration quota. And it consists of people with forced migration, such as refugees in need of protection, as I mentioned. You might be aware that Canada is one of about 150 countries to have signed the UN Declaration, meaning that Canadian government shows its commitment to protect the persecuted and the stateless. So Canada's a part of a very few countries which offer not just temporary protection, but also permanent resettlement. And so the Canadian government's immigration level plans stipulate that about 1 million immigrants will be admitted to Canada. And that was between 2018 and 2020. And that'll increase again. So the overall immigration portfolio from about 7.5 million to almost 12 million by the year 2036. So that's about 30% of the total Canadian population. And I just also want to note that while the global refugee crisis and people of forced displacement is great, overall, these numbers sound quite large, but it's actually a very small percentage of the overall people that have are under the category of forced migration and refugee. And so this small percentage, though, makes a very big difference in terms of what happens once people are resettled in Canada. And this is just a pictorial representation of what's happening across provinces. It hasn't changed, it's changed a little bit, where Ontario and BC, Alberta, and Quebec absorb the most amount of immigrant populations in Canada. But what's interesting to note is that in the last census period, BC received fewer recent immigrants than Ontario and Quebec and Alberta. And that Alberta is actually exceeding its immigration quotas over British Columbia. But by and large, it is Ontario, BC, and Alberta that absorb the largest amount of immigrant populations. So this is just another kind of a similar slide showing the same thing, with Ontario being the largest, and we can see how that's grown or decreased between 2010 and 2015. I will say that the territories are getting more resettlement, and that destining, in other words, where people go in Canada, once people settle or are destined to a particular province or city, they don't tend to stay. So there's secondary and even third migration across Canada post-destining. Okay, so again, this is sort of the same picture, where migration accounts for about 2/3 of the population growth. And something I wanted to point out is that migration and resettlement will be a key driver of, for population growth as Canada's population continues to age. And so we will continue to develop a multi-year strategy, again, primarily toward economic growth. So before I shift, so that was a brief overview of sort of the state of global migration and what's happening in Canada. But, you know, when we look at retrospective analysis around immigration, the first 100 years, most immigrants arrived from Europe. So since the 1960s, there's been a marked shift with greater immigration from Asia, Africa, Central and South America. So the mix differs across the provinces, and I don't really have figures on that. But I wanted to highlight that historically, who was coming into Canada looked a little bit different. So as I shift gears a little bit here, I just wanted to touch upon the fact that historically, we've actually, our policies have denied immigrants, ethno-cultural, racialized, and Indigenous groups the rights to social and material resources of housing, food security, that kind of thing. So, and this is something that's probably well known, that Canada continues and had needed cheap labor to build the economy. So many of the policies, though, while we were bringing people in, there was violation of human rights. And these are just some of the aspects of those violations that occurred in the Canadian context. And this also includes Indigenous peoples who migrated seasonally. So perception of migrants were influenced essentially by systemic racism, xenophobia, which contributed to more restrictive policies. So the selection of non-white European immigrants remained in effect until about 1967, when immigration policy was replaced by a colorblind system, which was called the point system, according to the applicants' human capital and what they were bringing to Canada. So I mentioned I was going to talk retrospectively, and I point this out because around 1979 to 2002, this was the first time that British Columbia and Canada received the most resettled refugee groups of forced migration, and they were called refugees, for lack of a better term, but they represented Chinese, Vietnamese, Laotian, Cambodian. And that was about 1 million people that were forcibly displaced due to political oppression. Australia and the United States also received the same groups, but with different integration and health-related outcomes. So of that, of about 60,000, 5,000 were resettled to the province of British Columbia. And I want to note that that was the first time that there was longitudinal research looking at integration outcomes, gender differences, and mental health effects. So there was national, for the first time, national attention, and that was led by Dr. Morton Visor. And he wrote very influential documents called After the Door Has Opened, which looked specifically at the mental health outcomes, and Strangers at the Gate. And also during that time in 2002 was the first time that our government developed the Immigration Refugee Protection Act. So what did that mean? That meant that we were no longer excluding people of forced migration that came to Canada with mental disabilities, HIV, and other communicable diseases. Most recently, we've seen a surge of the Syrian refugee crisis. So in 2016, that was the largest refugee settlement in Canadian history, with almost 50,000 Syrian refugees requiring humanitarian protection as a result of the Syrian Arab Republic crisis. This also included UK, US, Germany, and Sweden, who also resettled Syrians. So today, also we plan to, the government plans to resettle about 40,000 Afghan nationals as a result of the Taliban takeover. And what is important to note during this period, going back to the Syrian refugee crisis, was that you will notice that Canadian government changed its name to Immigration, Refugees and Citizenship Canada, IRCC. So historically, we always used Immigrant and Citizenship Canada, but we've made a firm commitment to refugees and people with forced displacement. So what came out of all of the work that was done prior with Morton Visor's work on Sea Refugees and After the Door Has Opened? Key findings suggest that trauma is compounded when people arrive in Canada. In other words, things like post-traumatic stress disorder or post-trauma stress we tend to see those in healthcare practices over time because people are when they arrive, they're focused more on labor employment, safe housing, security, those kinds of things. And for the first time after the sea refugee crisis, resettlement in BC and in Canada, we noticed that there were some gender differences with mental health and health outcomes looking differently between the men and women that were studied at that time. Men's health tended to be better initially and get worse over time, but there was a very, very minimal gender-based analysis. And so poverty and discrimination, there was a clear tie between economic employment and whether or not groups had good mental health or health related to cultural continuity. So that research by Morton Beiser showed that when those resettled communities had cultural continuity, when they were able to express their culture, actually had better mental health in the long run. So overall, there was some overarching themes and policy-related impacts historically in Canada, with looking at immigrant and refugee groups around the sick immigrant paradigm, which was really about sort of the middle of the 20th century, where there was this view that immigrants are sick and, the public needed protection. And so it's interesting to note that the legal system had changed toward protecting and including people coming with communicable diseases and mental disabilities. And so, yeah, and that's what I mentioned already. An overarching theme, and we'll come back to this just later in this discussion, is that we need to build a robust economy. And so we need to continue to keep our newcomers safe, healthy, because they will be the main providers of our economy. And so there's a social, political, and historical context that actually focuses on the promises of economic benefit and effects on building a multicultural society. In other words, keep them in discourse. And so that's related to needing to meet immigration quotas set roughly to about 200,000 a year. And again, this has to do with economic benefits. So immigration remains a key driver in advancing Canada's economy. By 2030, it's estimated that Canada's population growth will be exclusively on immigration and internationally skilled workers. So net immigration in 2018 accounted for about 80% of our population increase. There's also a need to advance Canadian society in terms of our multicultural heritage and policy around linguistic and religious diversity, in addition to human capital that migrants bring. I also wanted to mention that earlier this year, I attended a talk by Dan Hebert at the University of British Columbia in Center for Migration Studies. And I wanted to share that summary of that conversation, the impacts of COVID-19, where COVID-19 was described as a triple crisis that meant inequitable impacts on COVID-19 and health, particularly on migrant groups who've been disproportionately impacted and that are racialized, immigrant and refugees who have experienced social inequalities through economic impacts and greater hardships, and also a lot of them being women. So the Canadian Council for Refugees had a spotlight on migrants working in long-term care, bringing attention that workers were here on a temporary basis with fewer rights, and that they're particularly vulnerable to systemic monitoring, and that there's no systemic monitoring to ensure that their rights are protected. There was also an economic downturn during COVID-19, which had grave impacts for our newcomer groups that were employed, partially employed, or engaged in labor participation. Most affected are refugees that have lower language and literacy barriers. So in order to advance human and labor rights during the pandemic and beyond, it was incumbent on governments and policymakers to implement intersectoral, equity-oriented labor interventions. In Portugal, for example, all migrants were temporarily regularized and able to secure legal rights. And also that meant that they had a right, that they were given insurance to healthcare and social security during the pandemic. So during the COVID-19, mortality rates of ethno-cultural neighborhoods in Canada show disproportionate impacts of COVID-19 and mortality. And that was with higher proportion of population groups that were visible minorities. Studies in other countries like US have shown significant variation in deaths attributed to COVID-19 based on neighborhood level and determinants of health such as age, sex, ethnicity, and income. There's been a limited analysis of this in Canada to investigate differences in neighborhoods around visible minorities. Many groups have a higher, one theory is that many groups have higher poverty rates and are overrepresented in socioeconomically disadvantaged neighborhoods. So this picture really is about a census in the metropolitan areas of Montreal and Toronto that highlights numbers of deaths due to COVID-19, and the specific group has the highest proportion in Montreal is Black population, and in Toronto, it's the South Asian population. So a recent review highlighted also the disproportionate and longstanding health inequities faced by racialized communities and migrants in the context of the pandemic and the toll that it's taken. They argue that there's a need for intersectional, meaning intersectionality framework to expose both microsystems and institutional ideologies that reinforce inequities by racialized communities. And so that's a crucial understanding to the effects of COVID-19 and pandemic response about migrants in in high income countries, but it also points to ongoing things that we already know where immigrant health deteriorates over time. We have data now that shows mental health also with immigrant and refugees follows the same pattern and decreases over time. So there's a call for all jurisdictions in Canada to start collecting ethnicity data or race-based data. We have a small study right now looking at how this data is being collected at Vancouver General Hospital with people that are racialized that also have mental illness. So earlier I kind of showed what the Morton Visors work was on with See Refugees. Today we've moved the dial a little bit. AMSA, the Affiliation of Multicultural Societies and Services in BC, point to emergent vulnerabilities related to gender. Gender and identity in the context of migration are not separate categories, and mental health access across genders, men and women, and LGBTQ migrant groups. Women that have experienced forced displacement may have experienced gender-based violence, and it matters whether they come from rural or urban contexts because that impacts their ability to navigate some systems of health. In obtaining sexual and reproductive health services are problematic for migrant women, particularly where pregnancy may result in job loss or deportation. Men represent over half of the total refugees, and men also have unique vulnerabilities, but they receive fewer supports. And poorer mental health may be related to masculinity, change in gender roles, additional stress on financially, need to supporting the family, where men experience underemployment due to literacy and language barriers, and also increased injury and lack of protection in workplace settings. LGBTQ plus and gay, bisexual, and trans men may also experience discrimination and exclusion, pre-migration and post-migration, and in their existing diaspora. So where are we at today then? We see that language supports continue to be lacking despite provincial policy on language access. Every day I hear a story about someone not having access to a language interpreter and the difficulties that poses. Lack of knowledge about healthcare provider, about the interim federal health plan, the insurance that people can have, whether they're assigned, whether they fit an asylum category or any other refugee category. So this health insurance allows people access to mental health services and supports, but the problem is that providers need to be aware of it. But most first point of contact care arrives in settlement-based organizations and not primary health care. Health literacy and system navigation can be a huge barrier, with most newcomers going to walk-in clinics and seniors being left behind and not knowing how to navigate systems and being reliant on families that are often working or young children that might be in school. Mental health has posed one of the most significant health impacts of our newcomer communities. And again, the need to look at trauma as not a one point in time thing, but how it's compounded in terms of those social dimensions that I mentioned. And that gender mainstreaming needs to go beyond gender to look at intersectional analysis and disaggregated data. And so our government has really tried to instill that with looking at more inclusionary policies, addressing vulnerabilities, and building more awareness. So today, we are looking at the admission of resettlement groups in Canada. Canada will continue to open its doors to what we call the new and few to address cultural diversity. And you can see that the top countries include Syria, Eritrea, Iraq, and Afghanistan. And so these figures include those who require protection based on political, religious, sex, gender, and expression persecution. Here's a look at what's happening in our province. You'll see that in Victoria, to a lesser extent, receives newcomer groups, but it's projected that by 2030, BC will increase its immigration between 30 to 35%. And so that will remain similar to what has been observed recently. And the projection is that most people will be of Asian origin, and that group will be around 68.9 to 70%, while immigrants of European origin will represent a lower number, up to about 16. So the main countries of origin will be Eastern Asia and Southeast Asia. Although this report says that BC will remain one of the most diversified province, according to ethno-cultural indicators, it's also important to note that by 2030, about almost 40% of people will have neither English nor French as their first mother tongue. And so those aged 15 to 64 would belong to a visible minority group. So overall, we are projected between 80 to 81 of all province immigrants would be living in Vancouver. That was similar in 2011, but Victoria is also continuing to receive large numbers of people. And remember what I said, that secondary destining and resettlement happens all the time. And that's mostly for affordability reasons, sometimes for family and friends and social support reasons. Another finding is that, or a point of interest, so while refugee migrant health or in mental health is part of global action plan from the international organization IOM, they provide some statistical data on research that's actually done on refugee health. So despite what I've been talking about, health ranks as the lowest on the scale, with the majority of the research being done on labor development and climate refugees. So the other thing is that in general, that health and mental health aren't actually separated out, that they're actually integrated in some of this research. And in general, that it's interesting, we don't have enough attention on this in my view, but that in countries like Canada, we're actually not prepared for the magnitude of needs that include language interpretation, gender sensitivities, health literacy needs, health insurance, and all the things that I've already mentioned. So,
sorry, Nancy, I'm going to interrupt. Can you close off quickly, and then if
yeah. So, okay, I was told to increase my presentation, so I will close off quickly. So I just wanted to mention that my work has, after the sea refugee crisis, I've been involved with many migrant groups in Canada and British Columbia. We have a study going on now looking at a gender analysis with Syrian refugee men and their participation in labor employment and what that means to their mental health. For those of you that are interested, we have an excellent program on immigrant and refugee mental health done by the Mental Health Commission of Canada, which outlines a lot of what I said and a lot of how we can contribute to equitable, culturally safe mental health care. And finally, I will conclude by saying that the World Health, in collaboration with IOM and the UN, promote strategies that look at long-term and short-term public health interventions. There's a need for continuity and quality of culturally safe care. Mainstreaming of health needs to be done locally. Enhancing capacity to address social determinants, including mental health and universal health care. And finally, to improve evidence-based healthcare and counter misperceptions about migrant and refugee health. So in this presentation, I aim to highlight the current challenges and factors that influence mental health and well-being for newcomers so we can provide health for all and equitable and culturally safe care.